Hello and welcome to MRC Psych on the Go Revision Essentials. My name is Dr. Alapasurlicker and I'm a psychiatry trainee in the west of Scotland. Like many of you, I spent a lot of time commuting. This was valuable time that I could have spent revising for the MRC Psych examination. And so, I've started this podcast to help you revise on the go. Each episode breaks down one high-yield topic mapped to the syllabus. This is then followed by 5 questions to help reinforce your learning. So, grab your headphones, turn travel time into revision time, and let's get started. Last episode, we met a woman with severe amnesia who flinched away from a handshake she had no memory of ever feeling. Something in her had learned to be careful, even though she couldn't explain why. That patient, Claperett's patient, had Korsakoff's syndrome. This episode is entirely about that condition. What causes it, how it's diagnosed, and why catching it early can be the difference between full recovery and a permanent, irreversible amnesia. Korsakoff's syndrome is named after Sergei Korsakoff, a Russian neuropsychiatrist working in Moscow in the 1880s. He noticed a strange pattern in some of his patients. Their reasoning, language, and social behaviour seemed largely intact, but they simply couldn't hold on to new memories and would confidently fill the gaps with things that never happened. He linked it to alcohol misuse, though he insisted, correctly as it turns out, that it wasn't exclusive to alcohol. A few years earlier, the German neurologist Karl Wernicke had described a different acute presentation: confusion, an unsteady gait, and abnormal eye movements. The two conditions turned out to be stages of the same underlying process, which is why you'll often see them referred to together as Wernicke-Korsakoff syndrome. The underlying cause of both is thiamine deficiency, vitamin B1. Thiamine is a cofactor for several enzymes involved in glucose metabolism in the brain, so when it runs low, the brain's most metabolically demanding regions are hit hardest. These are the mammillary bodies and the mediodorsal nucleus of the thalamus, both key relay points in the brain's core memory circuit, connecting the hippocampus, thalamus, and cortex. Damage here doesn't erase old memories so much as break the mechanism for laying down new ones. Think of it like a filing cabinet, where the drawer for old files still opens perfectly well, but the machine that creates new folders has broken down completely. Left untreated, thiamine deficiency first tends to produce Wernicke's encephalopathy, an acute triad of confusion, ataxia, and abnormal eye movements, most often nystagmus. A useful mnemonic is CAN, confusion, ataxia, and nystagmus. It's a medical emergency, but only a minority of patients ever show the full triad, which is one reason it's so often missed. Thiamine deficiency itself isn't limited to alcohol misuse either. Prolonged vomiting, severe malnutrition, bariatric surgery and dialysis can all cause it. Remember, Wernicke's encephalopathy and Korsakoff's syndrome are 2 stages of the same thiamine deficiency process. The triad of Wernicke's encephalopathy, confusion, ataxia, and nystagmus can be remembered as CAN. If Wernicke's encephalopathy isn't treated in time or is missed altogether, it can progress into Korsakoff's syndrome, a more chronic and often permanent amnestic state. The hallmark is profound anterograde amnesia, an inability to form new memories, often alongside some retrograde amnesia affecting the recent past, while older memories tend to stay intact. Conversation, language, and immediate attention are often surprisingly well preserved. A patient can hold a completely coherent conversation with you and forget it ever happened the moment you leave the room. The clearest feature, and the one most people know Korsakoff's for, is confabulation. Patients fill the gaps in their memory with invented content, but they're not lying. They have no awareness that what they're saying isn't true. It's the same disconnect we saw with Claperade's patient in episode 35. A genuine belief with nothing behind it. Try this for a second. Without looking anything up, describe out loud, step by step, how you'd tie a shoelace. Notice how you know it, but the knowledge doesn't arrive as a memory of ever learning it. That's procedural memory, and it's one of the few things that often survives largely intact in Korsakoff syndrome, alongside implicit memory more broadly. It's why patients can sometimes learn new physical skills, even while being completely unable to recall ever practicing them. Remember, Korsakoff syndrome is characterized by profound anterograde amnesia, some retrograde amnesia and confabulation, with relatively preserved language, attention, and procedural memory. A useful mnemonic is CAP, confabulation, anterograde amnesia, and preserved procedural memory and personality. ICD-11 handles this differently from older classification systems. Wernicke-Korsakoff syndrome is classified primarily as a neurological and nutritional condition, coded under thiamine deficiency disorders, reflecting that it's fundamentally a physical disease process rather than a primary psychiatric one. Where alcohol is specifically the cause, ICD-11 allows an additional code, amnestic disorder due to use of alcohol, to be applied alongside it. That separates the underlying physical injury from its most common cause, rather than folding the whole condition into a single alcohol-specific diagnosis. Diagnosis is largely clinical. A history of risk factors, such as alcohol misuse, prolonged vomiting, or malnutrition, combined with the characteristic anterograde amnesia against otherwise preserved cognition. Neuropsychological testing can help confirm the pattern. An MRI may show mammillary body atrophy, though a normal scan doesn't rule the condition out. Blood thiamine levels can be checked, but treatment should never wait for the result if there's real clinical suspicion. This is a medical emergency, not a diagnosis of exclusion. Management of suspected Wernicke's encephalopathy is urgent. High-dose parenteral thiamine, given as Pabrinex in the UK, needs to start immediately, and critically, it has to be given before or alongside any glucose. Giving glucose first to a thiamine-deficient patient forces the brain to burn through its already depleted thiamine reserves even faster, and can actually trigger or worsen Wernicke's encephalopathy. It's one of the most classically tested points in this whole topic, and one of the easiest to get badly wrong in real practice. Once full Korsakoff syndrome is established, treatment shifts from emergency reversal to long-term management, continued thiamine replacement, abstinence support where alcohol is the cause, a structured, consistent environment, and cognitive rehabilitation with memory aids and routine. Prognosis is often loosely summarised as a rule of thirds. Roughly a third of patients make a good recovery, a third show partial improvement, and a third are left with permanent significant impairment. Many require long-term supported care. Remember, diagnosis is clinical, supported by neuropsychological testing and MRI. Suspected Wernicke's encephalopathy is a medical emergency, treated with urgent high-dose parenteral thiamine, given before or alongside glucose, never after. A final clinical note. Patients with Korsakoff syndrome often lack insight into how impaired they are, which can make them seem unconcerned or even falsely reassuring about their own memory. That's not denial in the psychological sense. It's a direct consequence of the same brain damage causing the amnesia. Approaching a patient's confident, confabulated account with curiosity rather than confrontation, tends to go a lot further than trying to correct them. Now, let's test your recall. I'll read out 5 exam-style questions. After each one, I'll pause for 10 seconds so you can attempt it before hearing the answer. Question 1. What is the underlying pathophysiological cause of Wernicke-Korsakoff syndrome? And which brain structures are principally affected? Thiamine, vitamin B1 deficiency, principally affecting the mammillary bodies and the mediodorsal nucleus of the thalamus. Key structures in the brain's memory circuit. Question 2. A patient with a long history of alcohol use disorder is admitted confused, unsteady on his feet, with abnormal eye movements. What is the diagnosis and what is the single most important immediate treatment step? Wernicke's encephalopathy. Urgent high-dose parenteral thiamine, given before or alongside any glucose. Question 3. A woman with Korsakoff syndrome tells you, in detail and with complete confidence, about a holiday she took last week that never actually happened. What is this phenomenon called, and how does it differ from lying? Confabulation. Unlike lying, the patient has no awareness that the account is false. She genuinely believes it. Question 4. A patient with Korsakoff's syndrome can't recall a single conversation from 5 minutes ago, yet has just learned a new card game and plays it correctly every time you return. What does this tell you about which memory systems are preserved? Procedural and implicit memory are often relatively preserved in Korsakoff's syndrome, even when explicit, declarative memory is devastated. Question 5. How does ICD-11 classify Wernicke-Korsakoff syndrome? And how can alcohol's role be additionally coded? Primarily as a neurological and nutritional condition linked to thiamine deficiency, with an additional code, amnestic disorder due to use of alcohol, applied where alcohol is specifically the cause. Let's summarise what we've learnt today. Wernicke's encephalopathy and Korsakoff's syndrome are 2 stages of the same thiamine deficiency process, most commonly linked to alcohol misuse, but not exclusive to it, damaging the mammillary bodies and thalamus. Korsakoff's syndrome causes profound anterograde amnesia and confabulation, alongside relatively preserved language, attention, and procedural memory. ICD-11 classifies it primarily as a neurological and nutritional condition, with alcohol coded separately as a cause where relevant. Suspected Wernicke's encephalopathy is a medical emergency, thiamine always before glucose, and long-term outcomes for Korsakoff's syndrome follow a rough rule of thirds: recovery, partial improvement, or permanent impairment. That closes the loop from last episode. Next, we take a closer look at Freud himself before returning to arousal, attention, and alertness as we continue through the states and levels of awareness. Thank you very much for listening to this episode of MRC Psych on the Go Revision Essentials. I hope this episode helped to move your revision forward. If you have any questions or just want to continue the discussion, you can find me on LinkedIn at MRC Psych on the Go, spelt MRCPYSCH on the go. This podcast is about making revision accessible. If you found it useful, liking and sharing it with others helps the goal more than anything else. That's it for today. I'm Dr. Alapazurliker, and as always, keep revising on the go.